Good morning, everyone. I would like to welcome you all to this informative Q&A session with the care providers from Columbia Asthma and Allergy Clinic in Northern California. And I would like to especially acknowledge the members of San Francisco Bay Area Food Allergy Network, parents of children with multiple food allergies, and our own Columbia Asthma and Allergy Patient Support Group from Facebook for submitting their questions about food allergy treatments. All of you have provided thoughtful questions, and we're deeply honored to have the opportunity to address these questions via video. In the interest of time, we've done our best to consolidate similar questions. So if you feel that your questions were not addressed, we're happy to take follow-up questions offline. Thank you again for your participation. I would first like to introduce our organization and also give a little bit of an introduction about our journey with oral immunotherapy. We initially started near Portland, Oregon in 2005, and at that time it was a single clinic, and we started with just a handful of employees back then. And in 2007, we had the opportunity to have a 14-year-old boy come to our clinic who had 6 anaphylactic reactions within 1 year. Each one of them required epinephrine use and a trip to the emergency room. And so he came to us and said, this strict avoidance is just not working out for me. I need a different solution to my severe food allergies. And I told him that currently the standard of care is strict avoidance of food and also carrying the EpiPen with you. However, there was an abstract published and was discussed in one of the American Academy of Allergy, Asthma and Immunology meetings that very same year. And I told him about this novel approach of desensitizing people to peanut allergy. And so I also let him know that no one in this world has gone through desensitization for multiple tree nuts simultaneously, which is what will be required in his case to give him the freedom to have food in the restaurant and not have to worry about accidental exposure to different types of tree nuts. He told me that he is a Star Trek fan, and he's willing to boldly go where no one else has gone before. And so at that point, we decided to follow the protocol that was published in the abstract and modified it for the multiple tree nuts that he was allergic to. And he then became the first person in the whole world to go through multi-tree nut OIT. And he was ultimately able to tolerate all those tree nuts, and later on went on to become a Navy officer. And we were very encouraged by his progress, and then over time we had more and more patients come to us to seek a similar type of treatment. And so we have since then desensitized nearly 2,000 kids and adults with food allergies of all different kinds, from peanut to tree nut to egg, dairy, soy, other legumes, fish, shellfish, and almost every imaginable other food. And over time, this success has led to a significant growth in our company, such that we currently have 12 offices in 3 states, in Washington, Oregon, and California. In California itself, we have 6 offices throughout the Bay Area, and our primary focus is to desensitize people who have life-threatening allergies to various foods, and allow them to live a normal life with their food allergies, and not have to worry about when they will have the next accidental exposure to that food, which may lead to an anaphylactic reaction. We have also, during this time, further modified our protocols and refined our protocols such that we are confident that we can achieve close to 100% success with our desensitization protocols. Over time, we have adopted additional modalities of desensitization, including sublingual immunotherapy as well as patch immunotherapy. And we have discovered over time in what situations, what type of therapy is most appropriate for the individual. And with all those different tools available to us, we are confident that there is nobody in this world who cannot be desensitized to whatever food that they are allergic to. And so I would like to discuss various aspects of this form of treatment in the context of answering the questions that have been raised by various individuals. The first question comes from the San Francisco Bay Area Food Allergy Network. So how long have you been treating patients, and have you seen any undesirable side effects of the treatment or recurrence of allergy later? And as I explained, we have been doing oral immunotherapy since 2007, and we have treated nearly 2,000 kids and adults with this condition, and we have nearly 100% success with our treatment. In the last 10 years, I can count maybe 10 individuals who did not complete our treatment for various reasons. In a few cases, the reason parents decided to stop the treatment was because of undesirable adverse reactions or very slow progress in the treatment. And that is one point I do want to bring out, that even though everybody in this world can be desensitized, for some individuals it can be a very drawn out, challenging process which can take months and possibly even years. And so it is very natural for some parents to get discouraged during the process, and one of our goals is to continue to encourage them during those times of setbacks, and continue to show them the possibilities at the end of this journey. And so if somebody stays with the program, everybody in the end can be desensitized. The undesirable side effects are all associated with possible allergic reactions. It is relatively uncommon for us to see a severe allergic reaction requiring epinephrine. However, almost everybody who goes through the process does require modification in our standard protocol because of one or the other adverse reaction. In most cases, those adverse reactions are mild and transient. They may include isolated hives, they may include abdominal pain, they may also involve a mild cough or sometimes nausea or some other form of skin rash. So different types of side effects can occur along the way, but we don't consider any side effect to be acceptable. In every case, when there is a adverse reaction, we respond to it initially by using medications to control that symptom, and in the long term by reducing the dose and going a little slower to build up to the desired dose for the oral immunotherapy. Have there been any case where patients lose their tolerance over time? Now, this is a very important question, and in the beginning, we do expect this process to be a transient process, meaning once you have built up the dose of the allergen so that you have reached what we would call maintenance dose, if you were to stop the dose even for a single day, the allergy is likely to come back. But over time, if you stay with the maintenance dose for several years, most individuals will have sustained tolerance of their allergen, so that they can reduce the frequency of their maintenance dose. Occasionally, if they were to completely stop taking their nut or food allergen dose, over time it is certainly possible for those allergies to come back. And so these individuals who have such severe allergy to those foods, they have to some extent a genetic predisposition to develop allergy to that food. And so regular exposure of that allergen may help to maintain their tolerance so that they are less likely to have a relapse of their condition. How many allergens can be accommodated by this treatment? So now we have treated dozens of food allergens on a single individuals. On many occasions, we have done simultaneous OIT treatment for up to 11 foods at a time, and we've also done food desensitization for more than 40 foods total as well in a single individual. So there is no limit in terms of how many foods you can be desensitized to. The way we look at our mission is to get to a point where you can live a normal life, go to any event that you want to go to, any restaurant that you want to go to, and not have to worry about checking ingredients of every item in the menu and worrying about when the next accidental exposure will happen. And until we get to that point, we don't consider our job done. And so if the person is allergic to 20 foods, then our goal is to desensitize the person to all those 20 foods, and that's how we approach every single individual. So this one individual states that we have egg, peanut, tree nut, and sesame allergy, and again, we have desensitized multiple individuals with allergies to all those foods, and that is very achievable. Do we use anti-allergy drugs in the treatment? And the answer to that is that we do not use any allergy medication to mask an allergic reaction. So let's say if somebody is getting an OIT treatment and they're developing hives every time they get their OIT dose, that's not a good situation. The right response to that is to lower the dose of their OIT treatment and get to a point where they don't have those hives every time they get exposed to that allergen. So what I tell to patients is that exposure that doesn't lead to symptoms is pathway to desensitization. Exposure that leads to symptoms is pathway to further sensitization. So our goal is always to give the dose in such a manner that symptoms don't develop. When symptoms do develop, we do treat them with medications. However, our goal is to not suppress or just mask the reaction and keep going up on the dose. That's a undesirable process of doing desensitization, which can lead to long-term allergic reactions and possible long-term complications. And so our goal is always to lower the dose so that symptoms don't continue. However, there is another class of medications, so-called these biological agents, and these biological agents can actually dampen allergic responsiveness, and use of these biologic agents makes a lot of sense in facilitating allergy desensitization, and we will probably be using a lot more of it if it wasn't that expensive. However, most of these biological agents are quite expensive, and insurance companies have approved these agents primarily for the treatment of asthma or other conditions such as chronic hives or chronic eczema. And so unless the person has those conditions, it's very difficult for insurance companies to approve those treatments for this indication. And that's one of the reasons we haven't used biological agents as often as we would otherwise be using them. But we have certainly used it in some cases where it was difficult to achieve maintenance dose without their use. Can we get copies of some scientific studies which might be behind the pathways of desensitization? And this is something I want to emphasize, that OIT is a very well studied type of treatment. There are literally hundreds of publications from very prestigious universities such as Stanford, such as Johns Hopkins and Duke, who have published multiple studies on oral immunotherapy. There are fewer studies looking at the mechanism of how the process works, and this is somewhat unfortunate that after decades of research on immunotherapy of many different types, our understanding of the detailed immunological mechanism of how immunotherapy works is still somewhat limited. One friend of mine, Dr. Eric Wombre, from the Benaroya Institute in Seattle, he has done some very interesting studies on the mechanism of immunotherapy, mostly with environmental allergens, but some with oral immunotherapy as well. And there are also multiple mechanistic studies published from Stanford, for example, and other universities such as Duke and Johns Hopkins. So we can definitely provide references for those publications. But the basic point I would make is that that there are pathways we understand at the molecular and cellular level which are responsible for this process. It is a very complex process, not fully understood, but the understanding that we do have does allow us to make decisions in terms of how we adjust the dose and how we respond to different situations that arise during the process. Other OIT offices don't seem to use sublingual immunotherapy in combination with oral immunotherapy. What is the advantage and evidence for continuing with slit drops once you've started OIT? It's an extra out-of-pocket cost. Does it help patients reach maintenance more quickly? And the answer to this question is that the vast majority of people who go through OIT only do OIT. They don't do slit in combination with OIT. Occasionally we do use slit in combination with OIT, and that is done in situations where we get stuck with a certain dose, where we're just not able to make any progress. So we've used slit as a way of breaking through barriers sometimes when we are stuck with that. In other cases, when the allergies are just so severe that it's not safe to start with OIT, then we may first start with slit and then transition the person to OIT. We also encounter some situations where the allergies are not very severe, or they don't appear to be very severe, so we may start off with slit with the hopes that slit may be sufficient to desensitize the person to their allergen, and in that situation we may then do an oral challenge, and if the person is not able to pass that oral challenge, then we can transition that person to OIT. So those are the three main scenarios in which we have combined slit with OIT. One scenario is where the allergy is relatively mild, or it appears to be mild based on the test results and the history. However, when we do slit, the person does not pass the challenge after that slit. So then we would do OIT to achieve the desensitization. The second scenario, where we're stuck at a certain dose and we're not able to make progress, we may use slit as a bridge to go past a certain barrier. And then the third scenario is where the allergy is so severe that it is not safe to start with OIT. So we will start with slit and then transition to OIT. What sort of costs are we looking at? Is this covered? And if so, by what insurance? And what do we need to be prepared for to make this work? What sort of time commitment will we be facing? How do we prepare? And these are all very good questions, and we can provide answers to these questions individually based on the individual circumstances. On average, most of our OIT treatment protocols last somewhere between 4 months to 8 months. Occasionally we will have somebody who will finish in 3 months, and occasionally we'll see somebody who will take a year or even longer to reach maintenance dose. But typically most of these treatments last for a few months. In terms of cost, many insurance plans do cover our services, and what we're offering are basically professional services that the allergists are trained to offer. This is a very important point I want to make, that OIT and all forms of desensitizations are ultimately professional services. We're not using any special medication to achieve desensitization. We're not doing any type of procedure or using any special equipment to do this desensitization. It's basically taking food that we would get from a grocery store and initially giving very small amounts, microscopic amounts of those foods, and then gradually building up on that dose so that the person gets desensitized to these foods in the process of building up on the dose. And so those are all services that can be covered by most insurance plans. My son is 5 and has a severe fish allergy. He's anaphylactic. is there any way to desensitize for his allergy? And we are one of the very few allergy practices in the whole world who has successfully done fish desensitization. And so fish OIT can be done just like any other food OIT. And we have treated some kids with very severe allergy, including allergy to the inhaled fish allergen. And so that is very achievable. And the only reason we don't do fish desensitization that frequently is because once you reach maintenance dose, you do have to eat substantial amount of that fish every day. And also there are a lot of variety of fish, and even though all fish have some level of cross-reactivity, but there are unique allergens in most fish, so we have to limit the number of fish that we can do the desensitization for. But with those caveats, we're able to successfully desensitize people to their fish allergy depending on the family's preference. Can OIT or SLIT be provided for sesame, sunflower, and fish? If we are having stomach issues after eating the food but not anaphylaxis and no IgE or skin reaction, is that considered graduating OIT? So these are two questions. Let me answer one after the other. We can most certainly do OIT for sesame, sunflower, and fish. In most cases, we will do the seeds together, so we can do a mixture of sesame and sunflower. And once we are done with that treatment, then we can do a treatment for a mixture of different types of fish based on the family's preference. Regarding the second question, as I stated earlier, any type of symptom is not acceptable. So if somebody is having chronic stomach pain, that means the dose of OIT is too high, and we need to lower the dose until those symptoms go away, and then we have to gradually build up on the dose again. So any type of symptom is not acceptable, and stomach pain is certainly one of the symptoms that, even though it is common, it is not acceptable. We have to lower the dose, and we have to find another way of building up to the maintenance dose. So that's something that we can discuss individually based on the person's reaction and the dose at which they have the reaction. We have people considered graduated from our clinic when they reach maintenance dose successfully in our office without having any adverse reaction to that dose. And all graduation means is that they don't need to regularly come to our office anymore for dose escalation. However, it does not mean that they are cured of that allergy. It does not even mean that they have achieved long-term desensitization. It is ultimately a transient desensitization only when they achieve their maintenance dose. However, a lot of extra work happens at home at their own pace after they graduate from our program. So most kids who graduate from our program are able to ultimately achieve what we call free eating status, where they can eat as much of that food as they want to without having symptoms. Additionally, it may take several years, but most people who graduate from our program are able to achieve what we call sustained tolerance, where they truly do become tolerize to whatever food they were earlier allergic to. And so that's a very important distinction that one needs to make, that initially when we're doing the desensitization, it is a transient process where if they were to stop eating that food even for a day or two, their allergies will come back, where when they get exposure the next time, they may have a reaction to that exposure. But as time goes on, when they keep taking their maintenance dose day after day over several months and years, the process becomes a more stable process, and it turns into what we would call persistent tolerance, meaning if they were to not take their daily maintenance dose, they won't have symptoms when they get exposed to that allergen again. But those are the things which we still need to continue to guide with as you go along. So once you graduate from our OIT desensitization program, it doesn't mean that you stop follow-up visits. You do still need to come back on a regular basis for follow-ups, so that we can answer all your questions as you're progressing in your journey, and at the same time we can also do follow-up evaluation to determine when this process is turning from transient desensitization to sustained tolerance. So that all needs to happen in addition to graduating from our program. What are the safety statistics of OIT for our practice? Second is mostly a statement that one should not go to any private practice saying they offer OIT, slit or even fruit challenges, but how do you satisfy yourself that the practice is safe? The answer to the first question I gave earlier, we have treated over 2,000 people with OIT, and we have no more than 10 individuals who did not complete the program because of the family choosing to not continue. However, anybody who has gone through the program has been able to achieve maintenance dose and is able to then tolerate the food that they are desensitized to. And regarding long-term safety, as I mentioned earlier, that if somebody has any symptoms at all while on OIT maintenance dose, we would consider that not acceptable, and we can treat that by lowering the dose and building it up again. Sometimes it needs to be done in the office, sometimes it can be done at home with consultations with us through phone or through telemedicine type of a visit. So we will work with you to find a way to get to a point where you have the maintenance dose being administered without any adverse reaction. In terms of how do you decide which OIT private practice to go to, in most states there really aren't too many OIT doctors who are providing that service. In the Bay Area, in the last year or two, there have been a couple of other practices which have started offering OIT, but one thing I would emphasize is that OIT is something that is highly specialized, and experience does matter, and it is not advisable to go to a doctor who hasn't been as committed and doesn't have the same level of experience that we've had with OIT and food desensitization. And the other thing I want to emphasize is that OIT form of treatment requires a very dedicated, committed, well-trained staff in addition to the physician, and so it takes a lot of effort to build a successful OIT practice. And so one needs to look at how much effort that practice is devoting to OIT, and whether there is after-hour phone access to the doctor who can walk you through any type of adverse reaction which may happen after hours, and should be available 24/7. And so that level of commitment is critical to the success of OIT treatment. Question about LEAP study. Sadly, because of this study, parents are now being blamed for causing allergies but not feeding foods early enough. But all babies are exposed to cow milk protein early and regularly via formula, bottles, or yogurt. Yet this early exposure didn't prevent milk allergies being the #1 allergen. On the other hand, babies are never exposed to coffee until much later in life, and coffee allergies are rare. Yeah, so this is a very interesting question, and I do want to address that. Early introduction is no guarantee that that allergy would not occur. These are statistical studies. So what they show is that, when you compare a population, one group of kids who don't get any peanut, let's say in the first 3 years of life, versus kids who get exposed to peanuts, let's say at 4 months of life. Kids who get exposed to 4 months of life have a much lower incidence of having allergy to peanut, whereas kids who get exposed to peanut at 3 years of life have a higher risk of developing allergy to peanut. So that type of study is giving statistically significant, very convincing evidence that early introduction is safer, and the risk of developing peanut allergy when introduced at 4 months of age is lower than risk of developing allergy if you avoid peanut until 3 years of age. But it doesn't mean that that allergy is not going to develop if you introduce that peanut at 4 years of age, 4 months of age. The other thing is that every food is different, and kids who are prone to develop allergies do often develop allergies. And so it's a very complex topic. And so one thing that we have recognized for a long time is that the GI tract, or the small bowel of a baby, is immature, and it remains immature until around 2 years of age, which means that it allows for relatively undigested food to enter into the bloodstream from the GI tract when the child consumes that food. And so a kid who's drinking milk at an early age is getting exposure to that milk, and some of that milk is entering the bloodstream. And so the risk of developing milk allergy is much greater earlier in life. And so when we look at kids at 1 year of age, 10% of those kids may have milk allergy. But when we follow the same kids at 5 years of age, that incidence may go down from 10% to maybe 3 or 4%. And so, kids do grow out of that milk allergy as they grow older, as their GI tract matures. And so that is also a phenomenon that is recognized and is well described, and it's been described for decades. So the distinction I would make there is that when we're talking about anaphylactic allergy, the risk of anaphylactic allergy does seem to be higher if we get exposed to certain foods later in life compared to when we're exposed to them earlier in life. And there is a high level of variability from food to food. And so there are some foods which naturally are not highly allergenic, such as rice or chicken. They're considered relatively hypoallergenic foods, whereas nuts and seafood and some other foods are just naturally more allergenic. And so these are very complex questions, and I want to emphasize that LEAP study is a very valid study. Its recommendations are valid as well, and I do recommend that parents follow that, but it's important that parents don't feel guilty for not following the LEAP guidelines 5 years before LEAP guidelines ever came about. So you only know what you know, and only if we knew, if we could tell what the future holds, we would of course change our behavior, but we did the best we could when we had the knowledge that we had. And so no parent should feel guilty for not following LEAP guidelines when they were not even available. And regarding the risk of developing dairy allergy and egg allergy and all those things, that's real, and early introduction sometimes does not prevent development of mild allergies, but in most cases it does reduce the risk of anaphylactic allergies. And so that's an important distinction that one does need to make. If a person graduates, do they need to eat that food every day for the rest of their lives? And if so, what is the average dose? And so the person does need to eat that food every day until that process turns into what we would call sustained tolerance. And sustained tolerance typically takes 3 years or longer of daily consumption of the allergenic food. And typically we try to keep our maintenance dose relatively on the low side. So for example, for peanut, our maintenance dose is only 5 peanuts per day. There are other OIT doctors who go up to 8 peanuts per day, or 10 or 12. So it's somewhat variable. From our perspective, higher dose is, from an immunological perspective, the higher the dose, the better it is. However, we have to balance what is ideal with what is practical. And for a lot of young kids, it's just not practical for them to eat many more than 5 peanuts per day. And so that's why we've come up with our guidelines based on what we believe is going to achieve our desired outcome and not overburden the family in terms of ensuring that the maintenance dose is given day after day. If a child can already eat baked egg, does that mean they're more likely to have success at OIT for egg? What is the success rate for teens for dairy, egg, fish, and shellfish? It is certainly a positive predictive indicator. If a child can tolerate baked egg, they're more likely to grow out of that allergy on their own if they continue to eat baked egg. But it's really not a guarantee. We've certainly had some kids who were able to tolerate baked egg but still had a really tough time with the OIT for the uncooked egg. And so uncooked egg may still pose challenge for some kids, but in general, one can say that if you can tolerate baked egg, you have a better prognosis overall. What's the success rate for teens for dairy, egg, fish, and shellfish? So in general, teens do have a little bit harder time achieving maintenance dose, and also appear to have somewhat higher incidence of reactions even when they achieve maintenance dose, and that is a multifactorial cause. One thing we recognize is that with teens, maintaining regularity is harder. You know, they have lots of activities and it's easy for them to forget, and on the one hand parents are relying on the teens to be more independent, and yet we also, the parents still need to be very actively involved in ensuring that their teenage child is still taking the dose on a regular basis, and so that poses some challenges. And in addition, there may be hormonal changes, there may be other changes which make teenagers a little bit more challenging. But having said that, we have plenty of teenagers who are doing very well with OIT, and we've done OIT for adults into their 60s. So there is no upper limit in terms of the age at which you can undergo OIT. What goes into the decision-making process in determining if someone is a candidate for OIT? We've been very about looking into OIT because I'm very protective of getting my kids' hopes up just to have them dashed. I know there's some risk, but having a better idea of the success helps us to decide if it's worth trying. And so I again want to emphasize that there is nobody in this world who cannot be desensitized, but it does require a lot of effort. It's not easy to go through the whole process. One has to come into the office on a regular basis for updosing for months, and almost everybody has one or two setbacks along the way when we have to lower the dose and go a little slower. But if one is committed to this goal, then I believe there is nobody in this world who cannot achieve the final desired outcome. My 13 months is in progress with Slit for his food allergies. During the 20-minute wait time, he insists to put his hands in the mouth. We assume it's because he's teething. Should we prevent him putting his hands in the mouth? So Slit is very much relying on the localized high concentration of the allergen, and anything that reduces that concentration is going to affect the efficacy of the treatment. So by putting a finger in the mouth, one could induce additional salivation, which may not be good for maintaining high concentration. However, I think the effect is going to be relatively minor. And eating or drinking during the first 20 minutes is strictly not recommended, because that can certainly reduce the concentration. Within the mouth, there is no special area, so we tend to give the dose sublingually under the tongue, but if it goes on the tongue or even in the throat, the immune system sees all that allergen pretty much the same way, so it's not that important that the dose stays within that confined region under the tongue. Our daughter is only allergic to cashew and pistachio, but eat other tree nuts without any issues so far. My previous allergist told me to make our daughter eat the other nuts twice a month. Dr. Jane told us to make her eat them twice a week. should I avoid to give her the safe nuts on the same day of an appointment, or is it safe for her to eat them whenever she wants? Whenever somebody has passed an oral challenge and is able to consume foods, it is recommended that those foods be consumed on a regular basis to maintain that person's natural tolerance to that food. However, how frequently that is done remains somewhat controversial. We have very much relied on the LEAP study and sort of extrapolated the results of the LEAP study and have stated that twice a week exposure is a good idea to maintain your current level of tolerance to that food. If somebody's getting exposure once every 2 months or once every 4 months, that person is more likely to develop allergy to that allergenic food. And so it's somewhere between twice a week and once every 2 months that would be the right answer. And again, the more frequent you can make it, the better it is. So that's where we would like to be, preferably twice a week. If it's only once a week, it's not so bad. But if it's once a month or once every 2 months, that may not be such a good idea. It is not a good idea to use these safe nuts on the same day as the day of updosing for the OIT. I would typically expose your child to those safe nuts on a different day than the day that she's coming in for her updosing of cashewed pistachio. How many patients have you successfully guided through OIT? What are your thoughts on OIT and EOE? What's your experience with anaphylaxis during maintenance? What is the per patient rate of anaphylaxis during OIT? I would answer each one of those individually. As you know, we have done over 2,000 cases of OIT, and we have not had a single case of EOE so far to our knowledge. And the reason we have achieved that level of success is just by recognizing early signs of a reaction and responding to those reactions appropriately by lowering the dose. The way I look at EOE is that it is the asthma equivalent of the GI tract, and so we have known for a long time that if we were to do allergy shots in an aggressive manner in people who have asthma, they can have exacerbation of their condition, and they can possibly have new onset asthma by having very aggressive buildup of allergy shots. And here too, it's the same principle. If we're very careful in how we go up on the dose of OIT, then the risk of EOE goes down, and that's I believe one of the reasons we've not encountered any cases of EOE in our group of patients who've gone through OIT form of treatment. Regarding the risk of anaphylaxis, that risk is real, and I would say that the approximate figure is about 1%. So about 1% of people who go through our OIT protocols do encounter at least one episode of anaphylaxis during that treatment requiring epinephrine. Almost everybody who goes through the treatment program will occasionally have mild reactions which do not require epinephrine but require other forms of treatment such as antihistamines like Zyrtec or Benadryl. And so that's the overall safety record of our program. And even people who do have a severe reaction requiring epinephrine, none of them have required visit to the emergency room. Most of those individuals do fine after they are treated appropriately, and they're able to go home after their reaction resolves. So it is overall a very safe form of treatment, and the outcome is very rewarding for the family who go on this journey. And so with that, I would like to conclude this question and answer session. And any question that I have not been able to answer, please contact us directly, and we will be more than happy to answer all your questions and help you in this process. Thank you again for your interest in learning more about food desensitization options. Thank you very much.
Hello everyone, my name is Renu Gandhe. I am a board certified allergy immunologist working here at Columbia Asthma and Allergy Clinic with Dr. Jain and his team for last more than 2 years now. I'm here to discuss some of the questions that were brought up by our patients or even people who are in general interested in treatments regarding food allergy specifically. So yeah, let's just go over those questions and see how we can try to answer and create more awareness about the treatment options that we have available at this point. So the very first question that I have, it's from PMFA group. I have a 15-year-old. Asthma triggers by any respiratory virus. Is he a candidate for OIT? If yes, how is updosing managed if patient is actively using nebulizer? Any complications from using steroids during OIT treatment? So the question, the answer to the very first question, is he a candidate for OIT? Of course, yes. Majority of the food allergy patients that we typically see in our clinic have active diagnosis of asthma along with their food allergies. So if you look at the atopic march, the way it advances, what we typically see is during very first few months of their life, during infancy, atopic dermatitis manifests. After that, as they get older, food allergies take over. And as they continue to get older and older, the diagnosis of allergic rhinitis and then asthma, typically manifests. So it is not uncommon to see that patients who have eczema, who have food allergies, also have concomitant allergic rhinitis as well as asthma. Now, every patient is different in terms of the severity of their asthma. Some might have just intermittent, like the patient in this question, where they have asthma symptoms only when it's triggered by a viral cold or something that they get exposed to, which is a known trigger, which could be allergic, non-allergic, irritant trigger, and they are symptomatic only during that time. As the trigger takes over. Other patients have more persistent form of asthma where no matter what, even if there is a cold, no cold, allergen, no allergen, they still can have some level of chronic asthma inflammation ongoing in their airways, requiring a regular or a controller daily medication on board. So the bottom line here is, no matter how severe your asthma is, there are now medications and ways available now to treat your asthma optimally. And as long as your asthma is optimally treated and well controlled, you are a candidate for oral immunotherapy or any form of desensitization, I should say. The problem is when the asthma is uncontrolled. So uncontrolled asthma, I would say, is a relative contraindication to start oral immunotherapy or even sublingual immunotherapy. Now, but at any severity, maybe it's mild, maybe it's moderate, maybe it's even severe asthma, we have very effective medications available, including the newer biologic medications that if we have to use them to control the asthma status and to get these patients going with their food allergy treatment very safely and effectively. During the treatment though, let's say a patient is going through OIT or SLIT and has an active asthma flare-up. So during that situation, of course, we do not advance the treatment for sure. Based on how severe the flare-up is, we in fact indicate or recommend reducing the dose down to either a 25% or 50% dose reduction, and that gives them enough time, and your body is not getting bombarded with the allergen at the same time when you're trying to fight off an infection. So that just gives some time for the immune system to calm down. Once the immune system calms down, you're about 80-85% better from your existing flare-up. Then we try to either first get you back to the regular dose and then start advancing again. So it is a very common finding, in fact, especially during winter season or even during spring pollen season when patients have allergic rhinitis. We see that their asthma symptoms are slightly worse, and if it is worse, then it's not advisable to updose on their food allergy treatment. Now, as far as the last part of the question is concerned, any complications from using steroids during OIT? I would say absolutely not, because steroids, especially inhaled steroids, I'm assuming, inhaled steroids in fact are controller medication for asthma, and as long as you're using it, it is in fact helping the airway inflammation to stay under control and get your asthma under control. And once we have that, your progress through the OIT will be much smoother without less of disruptions. So that's one thing that is in fact going to help us to get you through the treatment, and there is no contraindication or complication from the use of inhalers. The next question is, can the doctor please talk about treating eczema that is caused by eating a specific food? I know it's a non-IgE reaction. So does OIT and slit also cure eczema? If so, which treatment is better, OIT or slit, to stop eczema reactions? If not, what are the options? How is OIT performed if patient's eczema flares when he or she is eating the prescribed dose? After completing OIT or slit, will a child be able to eat a food and it will no longer cause eczema to flare up like it did before the treatment? Thank you. Okay, so this is basically what we are going to talk about is food sensitivities or food allergies that do not necessarily present as acute onset symptoms, but more of chronic delayed presentation, and if the desensitization will be helpful in these situations. Now, eczema, as we all know, is a very chronic inflammatory condition of the skin, and it has the etiology is multifactorial, where we know that you have to have that genetic predisposition, defect in the skin barrier, so that the skin is more sensitive and captures the allergens or irritants that are coming in contact with it. And also the third and very important thing is exposure to the allergens, which could be environmental allergens or food allergens or different irritants that we come in contact with. Now what happens is exposure. So whenever kids have this diagnosis of eczema, they get categorized as mild, moderate, severe, of course, based on how severe the problem is and how much of a disruption and medications that these patients are requiring. But when the studies were done to collect data regarding food sensitization, about 30% of patients who had or who have moderate to severe eczema have ongoing food sensitivities. Now, how do they present? How do these sensitivities manifest? There are three different types. One is acute, where you will see that a patient consumes something or a child consumes something and develops into acute hives, coughing, throat closing, so a typical IgE mediated reaction. Number two is delayed onset reaction, where a few hours later, so about 6 to 48 hours after exposure to or consumption of a specific food, the patient start noticing that eczema definitely gets worse. And number three could be a combination of both, acute as well as delayed. So the question absolutely, it's right, because if it is acute onset, it is mediated by IgEs. So patient who has a history of eczema and a known acute allergy to any particular food is a candidate for desensitization for sure. Now, delayed onset reactions are typically considered to be not IgE mediated. So how will the immunotherapy or desensitization will work in these patients? So now if we look at the mechanisms of action of the immunotherapy, it is not just reduction in the IgE levels, but ultimately in the long run, what the immunotherapy does is it actually induces production of regulatory T cells in our body, and these are the cells which are very important in maintaining or developing a tolerizing response to the things that you're coming in contact with or the foods that you're consuming. And also ultimately it helps to reduce the production of type 2 T cells, which are the cells important in production of the inflammatory mediators that we see responsible for mediating the chronic inflammation in patients who have eczema. So these are in fact considered to be the most important mechanism of actions for allergen immunotherapy. So if a patient has eczema and has known by history there are identifiable food triggers, and if we see that there is evidence of sensitization on skin test or blood test, even without acute reactions, these patients are still candidates for sublingual immunotherapy or oral immunotherapy, as ultimately the T regulatory cells are going to make sure that the body is going to be able to tolerate these allergens better and better in the long run. Now how about, and this is actually the same mechanism of action where patients who have allergic rhinitis and are sensitized to environmental allergens, where the exposure to these environmental allergens is contributing to worsening of their eczema, it is an indication to start these patients, on sublingual immunotherapy or allergy shots for their environmental. So it's basically the same mechanism of action. Atopic dermatitis is one of the primary, indicators or reasons for someone to consider allergy shots or sublingual immunotherapy for inhalants. Now the answer to the second part, of course, so again, you can desensitize to particular food via OIT or slit. And with this, now the choice between the two will depend on how severe the problem is and what is the, the baseline tolerance level. If we are, for example, if we are talking about milk allergy and there is a child who even consumption of minimal amounts of baked milk in a bread or a muffin leads to severe worsening of eczema, then we know that the baseline tolerance level is fairly low, and this child will benefit more from OIT rather than slit. Versus there is a child who has to consume about a scoopful of ice cream to notice some worsening of his eczema, then I would say, okay, since the baseline is not as low, we might be able to consider sublingual immunotherapy for desensitization as an option. Now, one thing though, since these are delayed onset reactions, we also need to understand that the treatment also might take longer. So, as compared to someone who has acute allergies, so it might last longer, the treatment on board. Right, the other thing what I wanted to say here was, with food sensitizations or some foods which are making your eczema worse, the recommendation by majority of the allergists is still avoidance and dietary elimination, and then about 6 months later, 12 months later, consider reintroduction of this food. What we know now that more and more data is coming up showing that prolonged avoidance of these foods from your diet can actually increase the risk of type 1, so IgE mediated reactions upon reintroduction to those foods. So I would say avoidance probably is not the best option at this point, and if we have a chance, we should try to intervene early so that we don't get to the point where a delayed onset reaction becomes, turns into both delayed and acute onset reaction for that food. Okay, and I think we can now move on to the next question. Okay, so I am just learning that OIT exists. I am in rural eastern Kentucky, and my 6-year-old is anaphylactically allergic to peanuts, allergic to milk, egg, peas, and skin tested positive for tree nuts and coconut. If I could access treatment for him, are all the allergens treated concurrently, or do you do the worst ones first or the least reactives first? I know it is very individualized, but in general, how often do people have to visit their OIT allergist, and for how long a duration? I just know I would have to travel quite a distance, and I'm wondering approximately how many months I would need to do that. What's the usual time span for treatment? How many office visits are usually required? I will take the estimates and ranges. If a child has multiple food allergies, for example, the most, of the top 8, how do you decide which foods to try first? Okay, so many questions regarding the actual treatment process. So let's try to, answer those. So the very first thing that we do here is based on the history and reviewing. If there is a recent set of labs and skin prick tests, we'll take those into consideration. So history, reviewing the labs and the skin prick testing helps us to categorize these allergens into the most severe ones versus non-severe ones. Now, based on that, first we can either consider starting OIT for the severe ones or sublingual immunotherapy for the not so severe ones. Which foods to choose from? It will depend on the preference of the family and the patient. Now what happens is, it depends on how many foods you are severely allergic to and how many foods you are not so severely allergic to. If there is one food or one group of food that you are severely allergic to, but it's easy for you to avoid, but there are multiple other foods that you are mildly sensitive to or mildly allergic to, but still you're having to limit those in your diet, it does impact your day-to-day diet and quality of life, and also nutrition wise we do get concerned about the impact of avoiding all these foods from your diet. So if that is the case, we probably can consider reintroducing or starting the slit for less severe foods first. Once the slit takes effect, we introduce these foods gradually back into the diet, and once the child starts tolerating these foods in a significant amount, we stop the slit, and after that we'll take over the more severe part. Versus in other case, let's say there are certain foods that the child is relatively mildly allergic to, but there are severe ones that repeated accidental exposures to these foods have led to ER visits and hospitalizations and just so much of disruption in everything, quality of life, the anxiety towards it, nervousness, and all these negative impacts the fear that can take over. In that situation, if it is okay at this point to not focus on the mild allergens, it is more important to focus on the major ones, we would consider starting the OIT first and get the child desensitized to the severe ones first. So every family has a different perspective, their priorities are different, so it depends on what they would like to proceed with. So talking about sublingual immunotherapy first, which we will consider for relatively minor allergens, and what we can definitely do is include multiple foods together, multiple foods from multiple food groups together. These can be any food groups, like let's say we are talking about eggs and dairy and nuts and grains, seafood, everything can be included together given that it's of the same or relatively same severity. Now with the slit, we typically have a 16-step build-up protocol. Each bottle, there are 4 different bottles that you have to go through. Each bottle has 4 steps. So as long as the child is tolerating the treatment well, we try to updose them once a week. And with that, we try to get them to the desired maintenance level in about 4 weeks, so 1 month. And after they reach the maintenance dose, they will continue taking the same dose at home on a daily basis at about, so as far as the reintroduction of the foods is concerned, this maintenance can be continued anywhere between 1 month to 12 months based on how chronic and how severe the problem is. For relatively minor foods where there was a very mild allergy, we can actually consider introducing that food back in about a month after the patient stays on maintenance, and we have seen a good success with that. Versus if you're talking about slightly more severe allergies and also more chronic presentation like eczema, these patients might have to stay on the treatment for up to 6 months to a year, and at the end of that we try to reincorporate the food back in their diet. And our goal is that the child is eating these foods in significant amounts, and they have incorporated these foods in their diet. Once we have made sure that majority of the foods from the bottle are reintroduced in the diet, then we will ultimately stop the sublingual immunotherapy. Okay. All right. Then I think we are coming to the last question. This is more about probiotics. So there are two questions, and they have, regarding probiotics, so I'll just address the, questions together. The first one is, I have heard differing opinions on the role of good and bad bacteria in the gut, and how that bacteria balance can be linked to more food allergies in children. I have also heard and read differing opinions on giving probiotics regularly to kids with food allergies to try and restore the gut. What do you recommend to your patients who have multiple food allergies? Do you recommend they start taking a probiotic? And if so, are there particular strains of bacteria that work best in trying to restore the gut? And the second question is, there is a lot of research showing that allergic kids have a different gut microbiome compared to those without food allergies. Mice have been cured by fecal transplant from non-allergic mice. Has there been any research on how OIT plays into this? Does OIT itself correct the gut microbial imbalance, or it works regardless of the microbial balance? Or if a child just doesn't have specific microbes, then OIT will not take. Any specific probiotic strains that need to be taken before starting OIT to make it more successful? Any insights into this would be appreciated. Thank you. Good. So probiotics. Probiotics we know are live these are bacterial organisms. And the idea behind that is when you take it orally, it colonizes, it gets into your gut, it colonizes the microbial flora, and it starts, it stays there, it populates there, and in a way that their presence in our gut should, the host should benefit from that, the presence of these bacteria, right? Now, how does it do that? How, there are some studies that have looked into it. There's, in fact, extensive research that has been done, seeing the mechanism of action, how probiotics work, and how probiotics are helpful in, either preventing, primary prevention of allergies or even curing allergic conditions. There have been extensive research that has gone into it. Now, some mechanisms of actions that were, studied during, these studies were done, they help the gut, the barrier function maturation process in your gut. So that helps to, avoid filtering just unwanted proteins and developing a more allergenic response, or intolerizing response, I should say. It also helps to reduce the inflammatory mediators production in the gut. It also helps to restore or regulate the imbalance between the Th1 versus Th2 type of cells. And also recently and most importantly, induction of regulatory T cells, which again is very helpful in inducing tolerizing response to whatever we are consuming. Okay. Now, these were the things that, led to, people started exploring further and further if these probiotics will be helpful in either primarily preventing the allergic conditions, or at least, even patients who have already developed allergic conditions, will they play any role in treating them? Initially, there are still promising studies that came out initially that showed improvement in symptoms. There also were studies that showed, reduced incidence or prevalence of eczema in pregnant mothers who were taking probiotics on a regular basis. There were also studies that came out which showed that patients who had evidence of sensitization to egg protein ultimately, did not end up developing egg allergy as compared to, when they were taking probiotics versus placebo. However, the problem with all of this is still very controversial, because when more and more studies were done to try to reproduce the data or replicate the data, we were not able to do that. It could be because, the strains used were different, the doses were different, the way they were administered was different, whatever that reason may be, but there is no consistency in the findings yet. So we still cannot say that firmly that, the probiotics are playing a huge role in helping prevention or curing the allergies at this point. Okay, so when I'm seeing these patients, also I would like to mention that study about peanut probiotic OIT that just recently was published. It's an Australian study where they actually did placebo versus peanut probiotic arm, and after these kids had maintained reached maintenance, they did a 4-year follow-up, and what they found out was the peanut probiotic arm, it definitely provides a longer lasting clinical benefits. And also the immunological changes, those were seen in these patients, were much more favorable as compared to the placebo group. Now this study is good, it's a good starting point. However, there are still some limitations because we did not have a plain peanut OIT arm in that study. So we cannot compare placebo with only peanut probiotic arm unless there is a peanut arm in there. And also this is the very first study. So as I said, this is a good start, but we need more and more data. So if more and more studies come out supporting these findings, then I would say yes, this is something that we should definitely incorporate in our practice. So at this point, my recommendation is when patients come in to see me, majority of them are already taking a probiotic. So if they are taking one, I just continue to take it. But if they are not taking one, and I just share all the available information with these patients, and again tell them that it's not absolutely mandatory. However, if there is the slightest potential for it to help towards the treatment, and in fact it's not causing any harm to the patient, then I say it's okay to start. And most of the patients are okay starting the probiotic, given that it still has a potential to help with the OIT process. The strains that I typically recommend, two most common ones that I recommend are Lactobacillus rhamnosus, and the other one is Bifidobacterium lactis, because these are the most well-studied strains, and the safety of these strains is very well established even in very young patients. So these are the two of the ones that are my personal favorites. Okay, so I think this is about. And as far as, again, there is one part that if the child doesn't have any specific bacteria, will he not take the OIT? I don't think we have enough evidence at this point, and even because many times we see that kids are not taking probiotics along with their OIT, and we still see a great success. So there is not enough data to say that, okay, if you have this bacteria, you're good. If you don't have this bacteria, then it will not work. So I would say we are still lacking that information at this point. Okay, so I hope this is helpful to you all. We would be happy to, see if there are any follow-up questions, and would be happy to answer those questions. And it was great talking to you all. Thank you.
So our first question is from the SFBA Food Allergy Network. I'd love to know about the process of getting started, especially with multiple known food allergies. Do you do a consultation, then a round of testing and challenges, and then lay out a plan? So the initial consultation consists of reviewing the patient's history and test results. We'll use that information to determine if the patient is a candidate for an oral food challenge, sublingual immunotherapy, or OIT, or a combination of these. If previous testing is outdated or incomplete, then we may need to order blood test or perform skin testing before finalizing our plan. The next question, again, is from the SFBA Food Allergy Network /PMFA group. I would love to know when the right time is to consult a practice like this. My son with allergies is 2. Would age 12 and 14 be considered too old? I have seen age limits of 17 years old and 21 years old, and the idea is OIT has to be done before the immune system matures. Is this true? If so, what is the optimal age for success? Is it harder to achieve success for adults? So with sublingual immunotherapy, we're able to begin treatment even in infancy. For OIT, we usually wait until age 2 or 3 until the child is more communicative, but there is no upper limit for either of these treatments. Most of our patients are children, but we have successfully treated many teenagers and adults as well without any significant hurdles. From an immune perspective, though, the younger we can begin, the better, but that is not necessary for success. So our next question, again, is from the PMFA group. Are you accepting new patients? Which clinics currently have wait list? So we are currently accepting new patients at all of our locations. OIT in California is primarily going to be done in Oakland, Fremont, Sunnyvale, and Redwood City locations. As far as a wait list, I do not believe that we have a wait list per se, but there may be time slots at some offices that are unavailable. So our next question is from the CAAC patient support group. We started SLIT and are currently continuing with SLIT drops while doing OIT for eggs and hopefully nuts. I see some people only doing SLIT for their allergies, and we were never given this option. What patients are candidates for doing SLIT only for allergies? So we use SLIT for different reasons. Most commonly, we're using SLIT to desensitize patients to their mild food allergies. With SLIT, we expect to achieve about a 10-fold improvement in their tolerance. Sometimes it's difficult to predict if a patient has no prior history of exposure to that food, and we're relying on previous testing. But after SLIT, we typically will perform an oral food challenge to determine the new level of tolerance to that food. If the oral challenge is passed, then the food can be incorporated into the diet. If the challenge has failed, then we may consider moving on to OIT for that food. So the other reason that we would use SLIT is if a child has begun OIT and has started to have difficulty with the updose process. We would continue their OIT dose and then add on SLIT to help them break through barriers. Once maintenance dose is achieved for SLIT, they will continue the SLIT dose daily while we begin to resume updosing on their OIT doses. So rarely we have started SLIT in a patient who's very severely allergic to a food. If they've had anaphylactic shock in the past requiring multiple EpiPens or ICU admission, and we anticipate that the patient will react even to their first dose of OIT, we can start with SLIT first and then transition them to OIT. The same may apply to a child who is too young to begin OIT. We may start with SLIT and then transition them to OIT when they're older. The last question I have is from the SFBA. Thank you so much for doing this. I'm curious about what the end result is, cross-contact safe versus able to freely eat, as well as what maintenance looks like for the different treatments. So for OIT, our maintenance dose will provide the child with bite-proof protection, but this means safety with cross-contamination as well as accidental ingestion of their allergen. If the desire is to be able to freely eat, then we'll talk to you about how to achieve this at home. It's usually done by either gradually increasing the daily dose or by slowly beginning to incorporate the food into the diet, in addition to their daily maintenance dose. To give you an idea of the actual maintenance dose, our maintenance dose for peanut is 4 grams, which is equal to about 5 peanuts. For milk, it's about half a cup, and for egg, it is 30 grams, which is about 2/3 of an egg. It's expected that the patient will continue to eat their OIT dose at least daily for many years.